It's the first time I've had this many people talk about health literacy and actually, I think, agree it's about change. It's about change. That's, in my personal experience, that's new. So it's just been great to hear. I'm not interested in the deficit model of health literacy at all, really. I will tell you that I firmly think that the Calgary Charter approach is the one that actually has an umbrella that includes all the other definitions except for the things that shouldn't belong, like inappropriate decision. And I've set out to test that and see if it actually works in real life settings. Our mission at the Canyon Ranch Institute is to simply make the world a healthier place. I have no problem with that as my normative goal. So when you want to talk about why you write a definition in such a way, for me it's because I want the world to be a healthier place. It's as simple as that. So what we do at Canyon Ranch Institute is design and put in place demonstration projects to try to show what a true healthcare system would look like if it actually embraced health literacy and prevention and an integrative approach to health. Now, we had a phone conversation with someone who has a long history in health behavior change in relation to exercise and nutrition, and we basically did a teach back with him and said, when you look over our materials, what do you see? And this is not word for word, but pretty close to what he said. And you know what? I've never heard it said this way before. That is the exact opposite of the deficit approach to health literacy. This is about what health literacy can do to help people make informed decisions and change their life. So we work this problem from that issue. Why? Because in the United States, we pay more money and get less back in terms of return on health than any other industrialized nation in the world, and chronic disease is the driver of that problem. Our hypothesis is that health literacy is the strongest tool that we have. So hopefully I'll demonstrate that it works. You all know this quick little history. This is pretty much where health literacy started. People having a problem with problematic language. All of those we can go through. I also have to apologize. I'm going to break all of the rules on health literacy in this presentation because I have to do it in 15 minutes. So I'm usually much more interactive and slower than I'm going to be. Sorry, but that's just the nature of it. So this is another example, right? People looked around the healthcare system. They found complexity. They sometimes found that it was really easy to fix. Boom, done, right? That's a no-budget health literacy solution. It works. But as we grow up, we started to look at social and health inequities. This is my favorite example of the last few years. You'll remember the bank bailout in the United States, the Troubled Asset Relief Program. This is the entirety of the form that the banks were required to fill out. They could add only a one-page addendum, and this is it. In the nutshell. Now, in comparison and contrast, this is the Arizona Medicaid and food stamp application form. This is the current application for both in Utah. This is the application in Ohio, and the Great Republic of Texas has decided that, in fact, they need a separate form for both Medicaid and food stamps that are each 23 pages long. So being the former academic geek that I am, here's the payoff on a per-page basis, on an annual basis, right? The bank's got over $200 million per page, and you can see there's a varying amount at each state level. Why? That's what happens when you build a talk on a Macintosh and show it on a PC. Sometimes the image doesn't show up. My fault. It was about 1 o'clock this morning when I dropped that picture. It was Paulo Freire, right? So you all know him, right? How do you read that world? What does it say about who's trusted and who's not, about the distribution of power in the United States and globally for that matter? Are the users of your form or institution someone different than you or someone like you? And that is how health literacy is actually used to control more than just someone's health status, but also the power and possibility they have to lead a healthy, fulfilling, and productive life. It, to me, is very much about equity at the end of the day, and empowering people to help themselves do it is better. So when we look at public health, right, is the system designed to include people or exclude people? And can we use health literacy as a basis to change that system? That is basically our open question in all of the works that we do. I'm clearly an advocate for that it will work, but we have to prove that it will work. And we do in all of our work base it on this is the fundamental model that underpins the Calgary Charter, right? Can people or can the health system, you can frame it both ways, it's explicitly there, can the health system help people find, understand, evaluate, communicate, and use information to make an informed decision? Can people do that on their own? It's a simple logic model. Does it hold together when you actually design something into place? And yes, underneath that are all those skills and culture and science, reading, writing, numeracy, and civic literacy, which is where the empowerment piece comes from. So it's not health education in this sense, right? Because the fundamental assumption isn't that if you drop information in someone's brain, they're going to comply. That's not the approach at all. So how does it look when we put it into place? I'm going to show you two examples. The first one is an intervention that we designed and put in place in Peru. We looked at the long history of theater of the oppressed, which some of you might be aware of, which is fundamentally based on Paulo Freire's approach to literacy, but Augusto Boal put it in place in theater. And there's a really funny story about how that happened. One day he was actually doing a play in Brazil where the topic of the play was to overthrow the government. And at the end of the play, where they literally didactically told the audience to overthrow the government, the audience stood up and said, guess what? We've got our guns hidden, but we didn't have enough people. Now that you're here with all the actors and your guns, we have enough people, let's go do it, right now. And the actors had no intention, and they had fake guns, right? They were not gonna shoot anybody, and the guns wouldn't work. And that's when Augusto Boal stopped and said to himself, I have to change the way that I do this. The theater presentations need to become interactive. The audience needs to become part of the storyline. The challenge there is that in that model, the community is basically always correct. There's no role for evidence-based information to inform decisions. It's whatever the community wants is in fact what the outcome of that process is. So we designed Theater for Health, which in fact brings an evidence-based sort of truth back to the process so that people can truly make an informed decision. In this process, it's an open-ended theatrical presentation. We addressed household hygiene in this issue, and as an aside, this was fully funded by the Clorox company, unbranded. So we never said the Clorox name. We never even directly said bleach. In fact, the first mention of bleach came from the audience itself because someone said, I've heard bleach can actually help you clean your house and make it safer. Is that true? And so that's where the intellectual capacity from the Clorox company came in. So the audience hears an open-ended narrative. You present a problem, someone gets sick, a child gets sick, and then you stop the play, you turn the audience and you say, what would you do about this? How would you actually change what you do to prevent that child getting sick in the theatrical story, which is a reflection of the community? How do we do all this? Very important, very first thing, formative research. If you don't go in and understand the community and the people you're trying to work with, it's not going to work. And this is true across everything that we do. And then in a back and forth dialogue with a role that's called the joker, who moderates between the audience and the theatrical narrative, you develop a solution. And then you actually invite people from the audience into the play, and they do it right there and demonstrate, and then have a conversation about would that actually work in your community. And it turns out that the theatrical space is a culturally safe place because it's fictional. So people will suggest things that they wouldn't actually try in their own life. But then when they see it demonstrated in front of them, they're more likely to adopt it. That's the underlying theory, anyway. So did it work from the Calgary Charter perspective? And no, I didn't include the logic model slide. It killed me last night, but I deleted it. And I'm not going to show you all the data, but here's the Calgary Charter model from a very contextual measurement point, right? We built this measure for that project specifically. Did we help people find information? Absolutely. All right, almost the entire community knew of the performances, which was a new source of information that they never had in their lives. Did we help them understand it? We had huge amounts of knowledge gain, not in one area, but in the whole robust, integrative health arena that underpins household hygiene and the implications of good and worse household hygiene. Did they evaluate that information? If you ask them, was it relevant to your lives? 96.2%. This is basically the entire community. This is working in the poorest of the poor in Peru, the hillsides around Lima. The environmental conditions of this community could only really be called atrocious. The sewage disposal system consists of a hand-dug hole in front of every house, and it all goes in there. And that's fine when it's dry season, but the minute it rains, it's everywhere. Did people communicate that information? Why do we include this in the model? It's so important. It is how people build a social support structure. If you want people to change something in their life, they can't dump it on their family, friends, and community without building that awareness that change is going to happen and support. Alcoholics Anonymous has known this for a very long time, right? You want to change something, you need social support. Did they communicate it? Absolutely. From pre to post, there was a 36% increase in how often people talked about household hygiene issues within the community. Did they use the information? Self-reported behavior change. This is a demonstration, a pilot, an attempt to start to say, does this model work and does it hold together in a sort of real world research terms? Almost half of the community reported that they've changed behaviors. And were they lying to us? Because people do on self-reported behaviors, right? Because they want you to feel good about them and vice versa. So we actually did microbiological swipes within the households, right? And that doesn't lie. So for E. coli and Listeria in the food preparation area, we saw a 34% decrease in positive samples. So not only did people make a behavior change in their households, it was making it healthier right off the bat. So that is, in a nutshell, sort of this first effort to see, does the Calgary Charter work as both an intervention design and as a series of outcomes, a logic model that can lead people to behavior change. All the data that I'm going to talk about is just on the public side, but we redesigned what the health system would actually look like in these projects. So we controlled the level of difficulty of the information, the type of information, and the way the information was delivered to demonstrate what a healthcare system could actually do in terms of a public health outreach. Now the same, did it hold together, right? So for the statistical geeks among us, I thank you. Scott, what would you, I would qualify these as very strong and positive results.
In social science, they're remarkable.
That's exactly. The strength of this model is fundamentally there. And look at the relation to confidence to make changes. There's your attitudinal component, right? That people's self-efficacy in relation to the ability to control their lives and make changes is a huge increase. And if you want to treat it as a scale, which I did, this is monstrous. All right, a scale that holds together that well. This, by the way, was all conducted in Spanish, of course. And I'm only talking in English today, sorry about that. So we really do begin to have some very strong statistical indicators that the Calgary Charter model is a very viable approach to health behavior change. So that's example number one. Example number two, and I told you I was going to go fast, sorry. I want to relay a lot of information in a short amount of time, is what we call the Canyon Ranch Institute Life Enhancement Program. And sort of the mission statement is reflected right here, right? If there is, to me, one and only one golden rule of health literacy, it's that you need to involve and engage people as early and often as possible. So once again, the formative research is how this program starts off, no matter how many times we do it. We've done it, we have this program running right now in 2 locations in Tucson with 2 different healthcare partners. We redid the formative research for each set, even though it's the same community. And in fact, we rewrite the materials for every Canyon Ranch Institute Life Enhancement Program site to tailor it to the community. There's your integrative health, there's your chronic disease. This is what the program essentially looks like. And we've redesigned the health system. It's an integrative team of health professionals at a healthcare provider organization. These 4 one-on-one consultations that are required, these ones are optional, but they're going to be required soon, are also required to be 1 hour long. So there's no 8-minute limit to this conversation. And in our training of the healthcare team, a number of physicians in particular have looked right back at me and said, what on earth are we going to talk about for an hour? And now 1, 2, and 3 years later, they want to talk for an hour with all of their patients because they found just exactly how rewarding it could be. It's very hands-on, very experiential, and it covers the range of the integrative model, exercise, nutrition, mind, body, spirit. There's a behavioral component, there's a spirituality component, which we deliberately don't call religion because it's not, right? It's spirituality, it's sense of purpose. So this is across multiple sites, multiple cultures. We have a site in the South Bronx, we have 2 sites in Tucson, one in a very small town in Missouri, which is as pure and white as you can get. The South Bronx is as Puerto Rican as you can get. South Tucson is a Mexican-based Hispanic culture, and Cleveland inner city African American by and large. The same model, the same evaluation rubric, a tailored health literacy intervention, but look at the outcomes across all these sites, right? Can people find information? 60% go to the sessions. Do I wish that was higher? Yeah, but people have lives and they have things to do. This is a 3-hour session once a week for 12 weeks. This is a significant commitment of time. 20% increase in health knowledge, 9 to 20% in self-efficacy, whether it's nutrition, health efficacy, right, exercise, self-efficacy, we do all those. They tell us that they share information with over 8 people on average. We have very huge changes in behavior change, and we do blood work, right? So we're seeing statistically significant improvements in C-reactive protein, hemoglobin across the board. And probably most remarkably, we cut depression in half at every site. And I think what happens is this chronic disease model, I have diabetes, my parents had diabetes, my grandparents had diabetes, I'm doomed to suffer a life dominated by diabetes, and they begin to pull back from the community and isolate themselves. They come into this program, they meet people who have the same experiences, they build a social support network, they experience small changes that feel good, and they just reinforce themselves, and all of a sudden their outlook on life changes, and that's why we're seeing 50% difference pre-post on the PHQ-9 depression scale. Now the funny thing about that is when you do the scale PHQ-9 in the South Bronx, they're terribly depressed. When you do it in Milan, Missouri, they're not quite so depressed at baseline, and I'm convinced that the difference is that in the South Bronx they're actually telling us the truth. Right? But the change is the same across those cultural interpretations of the scale, which I think again reinforces how strong the Calgary Charter is. So I think we're basically proving this, right? That this model works as a basis for intervention design and as the basis for an outcome measurement approach. Each of these fundamental approaches were tailored to the program. The next thing I think we need to do is get the resources to actually build evaluation tool from this perspective that can be used across programs and isn't context driven. And that is all I had to say. Thank you.